Hi, it's Brendan McGrath. I'm one of the intensive care consultants down at Wythenshawe in South Manchester. I've been asked to give a bit of a very quick overview of intensive care for the non-anaesthetists because I think a lot of us, unfortunately, are going to be asked to work in areas that we're not familiar with necessarily. And so I'm going to whiz through a quick guide, the sort of talk I've been giving on and off over the last few years. It's unscripted. It is me just talking about my own thoughts on what I think you need to know. So no doubt I will say something controversial or incorrect. There will be plenty of reference to policies and procedures and things that will be in place. But this is a quick whistle-stop tour through the things that I think are important for people asked to work in ICU, whether that's an actual ICU or a makeshift ICU. So we're expecting a big surge in patients who come to hospital with respiratory failure who are going to need critical care support. Initially, that will mean invasive ventilation, but obviously there'll be a transition and a step down from invasive ventilation back down to ward level care and all that involves. I'm going to start with a bit of an overview, so general considerations about working in an intensive care unit, some points for sort of safe and effective practice, think about infection control. Then I'm going to just whiz through the ICU daily review. I imagine that most people who are seconded to work in ICU are from a medical or a non-medical background. You're not going to be the key decision makers in intensive care. We're not going to be asking you to be triaging patients, deciding who comes, who doesn't come, rationing treatment, deciding on end-of-life care, etc. So don't worry about things like that. There are certainly lots of transferable skills that a lot of our workforce have that we can use to help as many patients as we possibly can, and that's what I'm going to focus about. And I'm also going to talk specifically about managing the COVID-19 patients, which we are no doubt going to see, but not forgetting that there are unfortunately going to be people getting critically ill for non-COVID reasons over the next few months as well, and talk a little bit about managing them safely. So there's going to be lots of unfamiliar staff. Typically, even on a unit that I work on, you meet new staff all the time. So introduce yourself, explain your role, explain who you are, ask questions, ask who they are, ask who they're looking after. It's okay not to know. So don't think we're expecting people to turn up on day one and know exactly how it's going to work. Even for those of us that have been involved in planning and thinking about how intensive care services are going to work, this is uncharted territory. So it's okay not to know how things are going to work. Don't worry about that. The person at the bedside may not be a nurse. The person at the bedside may not be ICU trained, and there may, in fact, not be a person at the bedside all of the time. So the way we organise critical care currently, sort of level 0 would be someone on the ward who's having sort of ward level observations, ward level interventions. Level 1 patients need a little bit more input, typically one nurse perhaps looking after 4 patients in a sort of specialist bay, for example, on a ward. Level 2 is what we call high dependency, where we've got patients who typically have one nurse between 2 patients. So those patients will typically have non-invasive respiratory support, maybe some cardiovascular support running, need a higher period of observation. And then level 3 patients are what we would call an intensive care patient. So they are people who are on advanced respiratory support, so on a ventilator, people who are having high intensity nursing interventions, such as renal replacement therapy, which is quite labour intensive, or people who are sick and need a lot of attention or a lot of monitoring. Now, we haven't got enough intensive care nurses, we haven't got enough intensive care staff, even with secondments, probably, to keep these standards up. And so the advice centrally is that we may well have to relax some of these staffing ratios, which might mean that in a particular bay or area of critically ill patients, there may not be that one-to-one staffing, but there'll be someone nearby. So please explain who you are, find out what the person in there's roles and experience are. Communication is really important, probably even more so when we're all working in unfamiliar environments, unfamiliar situations. One of the key messages for anyone who works on the ICUs is if you come and fiddle with something like change a ventilator setting, change a pump setting, do something around the bedside, please tell whoever's designated to be looking after that patient, because it can be, at the mildest case, annoying and frustrating to find out that something's changed, and actually quite significant for the patient if you've turned the sedation down or something like that and not told anybody. So communication is really important. The sort of staff that we're asking to work in ICU or these new intensive care units, you will have high quality transferable skills from whatever background you're in. Some of you will have worked in intensive care before when you were training or more recently, although we accept clearly that might have been a long time ago. But for the anaesthetist, if you can look after a patient having a long anaesthetic, you've got an awful lot to offer when it comes to looking after critical ill patients, because there's a huge lot of overlap. You're not going to be working in isolation. The regular, if you like, ICU staff will continue to lead the care and will continue to make decisions about these patients. You're there in a supportive capacity, and I don't mean that in a dismissive way. I mean that don't want you to worry that we're expecting you to make big decisions about our patients. It's okay to be concerned about working out of your comfort zone. That's really important. If I got asked to go and work on maternity, God forbid, I'd be absolutely bricking it. And I really don't mind sharing that. So it's okay to be worried. We're just trying to make things as easy as we can for all of us. Infection control is really important. So obviously routine care of every patient, whether they are COVID patients or just a general ICU patient. So we need to protect the workforce, protect yourself, protect others. And by doing that, we'll protect our patients. So typically whenever you approach an ICU patient, it's clean your hands, stick on some gloves, stick on an apron. You may need some specific personal protection for aerosol generating procedures in any patient. So think about masks, visors, and eye protection. Remembering that glasses don't really cut it when it comes to eye protection. There will be some specific things that we'll try and do. So our patients are vulnerable because they have multiple staff contact. The stress of critical illness obviously can hammer your immunity, and patients are susceptible to opportunistic and secondary infections. So remember to wash and gel your hands after patient contact and after you've taken your gloves off. Some particular infections like Clostridium difficile need specific interventions like hand washing. Some non-COVID patients will need special gowns, etc., depending on what they've got. We'll try and isolate those patients as best as we can, and they may well be inside rooms. Ask the staff looking after them. We may not be able to isolate our patients as well as we would like to. I think that's probably to be expected. And the sinks might not be at the bedside. So, just think carefully about infection control. For the COVID patients, we've got people who are at risk of COVID and people who we will know will have had it. So they need clearly the full PPE. They're likely to be in cohort areas or isolated if we can. There may be open circuit cohort areas. By that I mean patients who might receive CPAP NIV, although that's probably going to be limited or avoided, certainly in the early phases. But we're going to have to wean our patients at some point, which is going to mean extubation, possibly CPAP after extubation for some patients, and if they've got tracheostomies, cuff down, pressure support at some point. So they may be in open circuit cohort areas, which might need pretty much continuous PPE. That's something we need to work out. In an emergency, someone with COVID, protect yourself. Somebody nearby will probably have PPE on. Shout for help. The temptation will be to rush in, but remember these patients have highly infectious, potentially life-threatening problems, which we don't really want to catch. So think about yourself before you rush into an emergency situation. That's really important. But there'll be other people there. You're not working in isolation. Other general considerations when you're working with the critically ill. So remember good practice for lines. So aseptic, no touch technique, the same sort of stuff that we would do in theatre or whenever you're preparing or delivering intravenous medications. It's probably more important when we're thinking about drugs intensive care that other people will be drawing up drugs. We might be drawing up drugs. Remember to check them. Remember to label them, particularly if they're drugs that you're not familiar in drawing up and using, and drugs that you may not be administering yourself. Remember good practice around sharps, so get a sharps bin. So all the sort of stuff that you would normally do, just think about how you're going to do it for these intensive care areas where you're allocated for that day. Relatives are going to need some help with infection control. We're almost certainly going to be restricting visiting quite significantly, which brings its own problems for communication. But again, we'll think about and manage that. But relatives at the bedside will need at least gown and gloves, and they may well need something more if it's a COVID patient. Please help relatives remove and dispose of the PPE as well. And again, that's all of our responsibilities. So we've talked about that already. That's a spare slide, sorry about that. Okay, patients in intensive care may well be able to hear what's going on. We encourage our staff to talk to them, hold their hand, explain what they're doing, whether they're sedated or not. Most patients who wake up from critical illness will remember family being there. They'll remember people talking to them, they'll remember procedures sometimes. They can be quite traumatized by it. So we're trying to make the patient's life as easy as possible. So talk to patients, hold their hands, introduce yourself, explain what they're doing. And of course, some of our patients will be wide awake, but still, ventilator dependent potentially. So, they want to know what's going on. Introduce yourself. If you stood at the end of the bed, explain what your role is, explain what you're doing, and give them a bit of an update. Okay. General ICU management. So the sort of things I wanted to talk about was when you pitch up to an ICU to do a shift, what sort of things are we going to be doing on a sort of daily basis? And the best way to do that, I thought, was to go through a daily review. So typically we'll be asked to give the patients the once over and plan what's going to happen to them for the day. So this is an existing patient on an ICU. So typically we talk about the date, we talk about what's the day of ICU care. There's a lot of confusion about what's day 0 and what's day 1. Just as long as everyone's consistent, it doesn't really matter too much. But look at what the nursing documentation says, just so we're all on the same page. Labeling additional piece of paper is really important because we're going to be working on almost certainly handwritten documents in a lot of places. Make sure that the patient's name and details are on all the bits of paper that we use. A very quick overview of what's the working diagnosis with this patient. What are their main problems? Why are they here? Why are they on an ICU? Why are they on a ventilator, etc.? Have they got any relevant past medical history that's relevant to what we're doing today? We talk through the sort of general care in a systems manner. So it doesn't really matter what order you do it in, but our pieces of paper talk about central nervous system assessment, first of all. So, the conscious level. The Glasgow Coma scale is not that useful if you're sedated and ventilated, but it's familiar to lots of people. The vocal response to somebody with a tube down their throat is obviously going to be quite limited. But if a patient with a tracheostomy or an endotracheal tube is lightly sedated and can clearly interact with you, understand what you're doing and communicate to them, then I just stick in brackets next to it, V, put a little T, meaning they've got a tube. But then just explain, the patient clearly understands what's going on and they've communicated with me. So that, could easily give you a GCS of 15, even though you're not actually vocalizing. We're interested in focal signs. So our patients may be unconscious due to an underlying neurological problem. So CNS infection may be due to hypoxic brain injuries after cardiac arrests, for example. They're the common things. If you work in a neuro centre, primary bleeds or trauma, etc. We're looking for new focal signs. So if the pupils were equal yesterday and they're not equal today, then that's significant. We might need to do something about that. Are they moving all of their limbs? Because again, if they're not, then we might need to think about a head scan, for example. Think about analgesia in this section. Again, most people who are ventilated for respiratory failure won't need specific analgesia, but having a tube down your throat and being on a ventilator is unpleasant, and you need to be sedated. Sedation should be just enough, but not too much. Trying to get that balance can be tricky. The more sedated you are, the easier, arguably, you are to manage because the patients just lay there. But we're storing up trouble for ourselves later, because when you switch the sedation off, try and wake them up, if it takes 2 weeks to wake up, then we've not done ourselves or the patient often any favours. So we keep them just adequately sedated if we can. Staffing can be a problem. So if there's less staff around, obviously sedation holds need to be planned, and lighter sedation might need to be balanced against the number of staff there to keep patients safe. For adults, typically we'll use propofol. If you get more than about 300 milligrams propofol per hour, we start to get a bit nervous about lipid syndromes, etc. So we usually always use propofol with an opiate. Which opiate? Again, it doesn't matter too much. We tend to use alfentanil because it's relatively easily metabolized. It doesn't accumulate too much. Morphine's cheap and readily available, but it accumulates and its metabolites accumulate. Remifentanil is great, but you've got to be careful of bolusing it. It's expensive and we can get through it pretty fast. So something like alfentanil is probably about your best bet. With all the sedatives, just remember the infusions will accumulate. So if you turn an infusion rate up, tell someone and then think about when you can take it down. Boluses of opiates and of sedation are probably appropriate for rolls and turns and procedures, rather than turning up the infusion rate, because it's very easy to realize the next day that they've been on 10 mils of alfentanil by mistake for 12 hours, which isn't great. You can turn sedation off, and the patient's not going to suddenly wake up, depending on what it is. But if you're going to reduce or turn sedation off, just make sure that everyone knows you've done that. If patients have high sedation requirements, then they might need adjuncts. We try and avoid midazolam if we can. That has real problems for delirium, but you can use things like clonidine, dexmedetomidine, which is fortunately quite expensive, but they work pretty well. Careful with bradycardias with those sort of adjuncts. If you're really struggling though, midazolam is pretty cardiac stable, it's cheap, it's easy in its infusion, just be careful to use as little as possible. Patients may need paralysis as well, so they need to be adequately sedated before you paralyse them. It's good practice to stop the paralysis at least once a day just to check that they're adequately sedated. We don't tend to use neuromuscular blocking monitoring, but of course that would probably be good practice. But you're paralysing them so they can tolerate ventilation, not as a substitute for good sedation. Okay, the sort of scales we use, this is the RAS, the Richmond Analgesia Agitation Scale. That there are different scales about. You're looking ideally for the lightest possible sedation that allows you to do the care that you need to deliver to that patient. If, for example, a patient is not paralysed and they don't cough on suction, they're probably a bit too over-sedated. But if they're interacting with the ventilator and not ventilating adequately, then you might need to sedate them a little bit more. And as we move into spontaneous ventilation and lighten the patient up, then ideally you want them to be calm, perhaps slightly sedated, but not agitated, and certainly not combative, where they're a danger to themselves and a danger to staff. Other sedation scales are available. Just use whatever the nursing staff are using. Okay, respiratory assessment. The sort of things I'm interested in as an intensivist are how much oxygen they're on, how it's being delivered. We look at an arterial blood gas. In a crisis, we're not going to have loads of blood gases, but if you change something on a ventilator, then you want to see a blood gas, within an hour or so, I would imagine, afterwards. We want to know about the mode of ventilation, and I'll talk about that in a second. That might change obviously over the day, and some sort of ventilatory strategy is really quite important. We don't need hyperoxia. We need patients to be oxygenated just enough. So if you are a patient with existing lung disease, then SATs of 88 to 92 are probably fine. A PaO2 of greater than 8 is probably fine. If you're a young, healthy patient, then SATs of 92 to 94 are probably fine. Perhaps a slightly higher PO2 target, but PO2s of 9 and 10 are perfectly acceptable. In terms of CO2, again, we don't strive for a normal CO2 with our ventilation. Permissive hypercapnia is a strategy that allows us to ventilate with lower pressures and lower volumes. And part of that sort of ARDS prevention strategy is to ventilate with ideally 6 mils per kilogram ideal body weight. And we'll talk about calculating that in a moment. But if you ventilate with those relatively low tidal volumes, you will probably get a bit of hypercarbia. That's not a huge problem. We can manage that. And there are strategies, if we're not able to manage that we'll talk about as well. The sort of ventilators we will use might be different. We might be pulling out some old ventilators, using some unfamiliar ventilators, but they all do the same sorts of things. So pressure modes, volume modes, or sort of hybrid modes where we're blowing in a pressure or a volume to inflate the lungs. There's lots of subtleties in there, but that's the basic principle. The feedback on the COVID patients is that the lung compliance isn't too bad, certainly to start with. And so we shouldn't have too many problems ventilating them to start with. Compliance will change with the different bits of the lung. It will change with the disease progress, particularly if they get secondary infections or ARDS develops. It will change with positioning. It will change with PEEP and your ventilation strategy. And it will also change with how much fluid we give. So the wetter the lungs, the less compliant they typically are. So this isn't meant to teach you to suck eggs, but it's a refresher, perhaps, for those of you that aren't ventilating people regularly. Mandatory ventilation is where the ventilator does all the breathing, called intermittent positive pressure ventilation, continuous or controlled mandatory ventilation, trade names like BiPAPs or bi-level positive airways pressure, where you've got an inspiratory pressure and an expiratory pressure. It can be volume controlled or pressure controlled or a combination of both. Typically what you do is set an inspiratory pressure and an expiratory pressure, which is your PEEP if you're breathing fully ventilated, or technically CPAP, continuous positive air pressure, if you're breathing spontaneously. Doesn't matter too much. That delta P, the difference between the inspiratory and expiratory pressure, will generate a volume. And the volume is measured if that is what you are setting your ventilator to do. The volume can be set or controlled in a volume controlled ventilation or a hybrid setting where you say, I want a minimum of this volume within these parameters. But essentially you're delivering a set pressure for a set period of time, inspiration and expiration. And then the difference in inspiration and expiration gives you your IE ratio. Patients who are hypoxic, the first thing we would do is turn up the FiO2, obviously, but you're then thinking about a ventilator strategy that will help to improve their oxygenation. Typically, we will manage them with increasing the inspiratory time. Now, set vent rates of 20 or so will mean that you've got less time for the respiratory cycle, so you need to reduce the expiratory time. So we typically breathe with an IE ratio of about 1 to 2.5 at rest. You typically start on someone with respiratory failure with an IE ratio of about 1 to 1.5. So if you think about 20 breaths in a minute, you've got a 3-second respiratory cycle. So an IE ratio of 1 to 2, you've got 1 second in, 2 seconds out. So I'm not going to do the maths on the fly in my head, but an IA ratio of 1 to 1, you've got 1.5 seconds in, 1.5 seconds out. The less time you've got for expiration, the more likely it is that the patient will not exhale completely in that time. So compliant lungs with no airway restriction, you breathe in, we breathe out pretty fast. So you don't need that long in expiration. But we can look at that by looking at the flows on the ventilator. So the first breath on the left here, you've got the flow goes in with the ventilator breath, and then the flow comes out. We've got a long expiratory time, and that patient's got a long time to exhale completely and empty the lungs out. The next breath comes along, and you'll see that the patient starts to breathe out again, but before the flow has got down to zero, before the lungs have emptied out, we stick another breath in. So there's not enough expiratory time here. Where the blue arrow is the next breath. This is breath stacking. So you can look at the flow to work out how little expiratory time you can get away with. And you can sometimes use that to your advantage if you're trying to generate a bit of PEEP, but typically, to start off with, we are looking to have an expiratory time long enough to let all the gas out again. So the only gas in the lungs at the end of expiration is what we allow to be there through our PEEP setting. And so we'll be adjusting the IA ratio to that sort of parameter. If they're hypoxic, we'll be pushing the PEEP level up as well, don't forget, and I'll talk about that a bit later on. Now, the ventilator modes, most of the ventilators will have a trigger window. So if you imagine a patient who's completely paralysed, we're doing all the breathing for them. We don't tend to run our patients paralysed if we can. So just sedated enough to be ventilated, which means they can breathe a little. Now, in a mandatory mode, what that typically means is that the ventilator has what we call a trigger window. So before the next breath is due, if the patient starts to take a breath, the ventilator detects that and goes, they're trying to breathe. And the ventilator will know that they're about to do a ventilator breath, and they'll move that vent breath forward a bit in time. And so when the patient starts to breathe, they'll deliver a ventilator breath at a slightly different time than the ventilator was planning to. So they're pretty clever, these ventilators. And so they'll try and mandatory ventilate the patient in sync, so synchronized intermittent mandatory ventilation. Now, if the patient starts to breathe a bit more, which is generally good, it keeps the diaphragm and respiratory muscles going. It can be a pain if the patient's got high ventilator requirements, because it starts to interfere with the ventilation. So we just got to keep an eye on that. But we can set the ventilator to allow some spontaneous pressure-supported breaths. So this patient has taken a purple breath outside of the trigger window, and we've allowed the ventilator to recognize that, and this is spontaneous pressure-supported breath triggered by the patient, but either side of it are ventilator set breaths. So this is a patient then with set mandatory breaths who's been allowed to breathe with the odd breath supported by the ventilator. Now, the odd breath is fine, particularly when the patient is still sick. But at some point, as we lighten them up and as they transition from being fully ventilated to trying to get them off a ventilator, they will start to breathe a bit more. You can see that the patient here is breathing at random times. So they're controlling their IE ratio, they're controlling their respiratory rate. If you've got high ventilator requirements, high pressures, high FiO2, breathing like this will lead to de-recruitment. So just be careful when they start to breathe. That's generally okay, but if they've got high vent requirements, typically we need a few vent breaths in there still. And if they're not ready, i.e. too much pressure, too much oxygen, we keep them on some mandatory ventilation. The weaning process is a reduction over time in these pressure-supported breaths, just like you're waking someone up at the end of an anaesthetic. You might have them on some pressure support to start with, that's then reduced and removed. We're looking for a spontaneous breathing trial at some point before we liberate them from the ventilator. And there's different ways of doing that, but essentially you're looking to see, can they breathe without significant support from the ventilator through the ventilator circuitry, to judge whether we think they're going to successfully extubate or not. Breathing through the vent circuit, requires some additional effort. So there's usually some pressure support that is still required. So a little bit of pressure support, sometimes called ASB, assisted spontaneous breathing, or some stealth mode on the ventilator where it slips in a bit of tube compensation. Don't worry about that too much. It's basically a little bit of pressure support designed to overcome the resistance of the circuitry and the breathing circuit for the patient. So typically a spontaneous breathing trial will be performed to check the patient can breathe adequately to predict whether they're going to successfully extubate or not. Patients who've got COVID, we don't want to be extubating them and then having to initiate pressure support like CPAP or potentially high flow if we can avoid it. And we don't really want to be re-intubating them. But, you know, it's a tough call whether we extubate patients successfully or not. But that's the general strategy for moving from spontaneous breathing, fully ventilated, allowing a few patient breaths, then more breaths, followed by spontaneous breathing and then spontaneous breathing trials. That's the typical path for a ventilated patient. We think patients are ventilated for 5, 7, maybe 10 days with this COVID disease, but we've not really got a feel for it yet in this country. This just shows a pressure could be flow diagram for the pressure support assisted spontaneous breathing. So we've got CPAP, continuous flow. When the patient breathes in, typically we have a drop in pressure. So the vent is set to deliver some support to make sure that actually when the patient's breathing spontaneously, that it's less effort, not more effort for them. Okay, that's breathing in a nutshell. Cardiovascular support. So can you hear the heart sounds? Is there some new heart sounds? It's pretty tricky to hear sometimes if they're on a ventilator, but you know, it's part of the sort of general clinical assessment. Heart rhythm. Typically patients go into AF when they're critically ill. Not everybody, but that's the commonest rhythm that we see. AF management is about checking the electrolytes, particularly potassium. Try and keep it over 4.5 if you can, bearing in mind their renal function, but it might be creeping up anyway. Is the magnesium normal? So ideally magnesium over 2, forget that, over 1. And we sometimes push it to around 1.2 or higher with a bolus if we need to. So just to be clear, magnesium over 1, not 2. Is there a reason why they've gone into AF? It might be that they're getting a bit light. It might be that there's a new problem happening when they get pyrexias or rigors, or they're in pain. There might be a stimulus or a reason why they've gone into AF. Think about central lines. The line might be a bit far, tickling the atrium. That sometimes happens. They might be dehydrated, intravascular deplete. Think about a fluid bolus, but be careful because, as we'll discuss in a sec, the overall management strategy for patients with COVID infection will be to keep them dry. The commonest drug we use to manage AF once we've done these basic things is amiodarone. So typically a loading bolus of about 300 milligrams over an hour, followed by an infusion if it doesn't go away. We can sometimes predict that patients are going to go into AF, particularly as we lighten them up. And if they're cardiovascular unstable, we might start some amiodarone sort of preemptively. But that's the commonest drug we use. Biggest issue with amiodarone is we've got to remember to stop it, particularly if they're leaving the critical care environment. So I don't really want patients being committed to being on amiodarone for long term, because as I'm sure you're all aware, it's not a great drug long term. Vasoconstrictors. So target blood pressure depends a bit on what the patient's normal blood pressure is. So if you're normally hypertensive, we would have to run the patient at close to their normal blood pressure. For most patients, we can run with a map of 60 or 65, and we tend to target mean arterial pressure, which most of the invasive monitors will display. Absolute values vary. So when people go to sleep, their blood pressure drops. The sort of targets we're looking for are they peeing adequately, and is there any evidence of end organ hypoperfusion? So urine output, 0.5 ml per kilogram per hour is fine. If the base deficit is okay, not getting any worse, if their conscious levels are right, if they're awake, if they're coronary perfusion's okay, if their renal perfusion's okay, then that blood pressure is probably adequate. Some patients, despite a good cardiac output, will need a particular pressure. So typically the hypertensives, if you drop below a particular threshold pressure, particularly older patients with stiff arteries, we find that they need a particular pressure, not necessarily a cardiac output to pee on, essentially. Patients who are septic will be vasodilated. So I tend to talk about or think about cardiovascular support in terms of vasoconstriction for people who are vasodilated, and then inotrope for people who've got evidence of hypoperfusion and a pump problem. So the three things think about are volume, vasoconstriction, and then inotropy, so pumping. Sedatives will vasodilate you, and so they're almost invariably going to need some vasoconstriction. And if you're deliberately going down a dehydration strategy, so people who've got acute lung injury, we try and run them a bit dry. So they're going to probably be a bit tachycardic. Hopefully they'll have their own sort of hyperdynamic circulation, but they're likely to need a little bit of vasoconstriction. The more vasoconstrictor you use, the more we worry about gut or splanchnic blood flow and periphery. So, you know, it's all a bit of a balancing act. But typically they're going to need a little bit of noradrenaline. That's what we tend to use as our first line vasoconstrictor. We obviously have to give that down a central line. Metronidazole or aramine as a peripheral vasoconstrictor is okay if you've not got a central line, but I think if you're needing a vasoconstrictor, then the safest way to manage that is put in the central line and use noradrenaline. If you're on an intravenous vasoconstrictor, then you're going to need an arterial line, invasive arterial monitoring. You might be able to get away with that in theatre for a short period of time, but not in someone who's going to need it for a couple of days. Inotrope. So indications would be evidence of end organ hypoperfusion, which can be a fluid or a volume problem. It can be a pressure problem sometimes, but worsening base deficit, tailing off urine output, cold peripheries, so from clinical examination, evidence of heart failure. Look for a cause. So ECG, is there an ischemic event happening? Is it simply that the patient is hypovolemic? So remember that one of the simplest inotropes you can give is volume, a volume expander trial. See if you can increase the stroke volume. Think about an echo. An echo can be quite useful just to see what the pumping state of inotropy is. Think about the rhythm. And you might need to think about some invasive cardiac output monitoring. So typically an esophageal Doppler would be something that a lot of anaesthetists are familiar with. So stick in a Doppler just for a quick look to reassure you, tell you you're on the right lines, and you can then target your volume challenges if you need to give volume. Heart-lung interactions are quite important, particularly with the right heart. The higher the intrathoracic positive pressure, the more trouble the heart can be in. It can be good. So a positive pressure in the center of the chest provides a transmural pressure to the heart, which can help with inotropy. So that's why people with heart failure, when you stick a CPAP mask on them, that's why they get better quite quickly, because it's a positive inotropic effect. That can also be why when we extubate people who've got a bit of heart failure, when you remove that positive pressure, that's why they can drop in a heap quite quickly, because positive pressure at low levels is good for the heart. At higher levels, it can start to become a problem because you start to squash the right heart, compromise right heart filling, and raise pulmonary arterial pressure. So an echo, again, can be quite important in those situations. And if the heart is struggling, sometimes what we have to do is back off with the inspiratory pressure. Sometimes there's a trial to see if that helps, or sometimes definitely, and for longer periods of time, if we see that dropping the inspiratory pressure actually helps with the heart pumping. As you go up with inspiratory pressures, you are likely to need to have volume resuscitate the patient to increase those intravascular pressures. Again, if your strategy is to keep someone dry, just be a bit careful with that, but bearing in mind that you can't just stick someone on high pressures straight away. You've often got to gradually increase the intrathoracic pressure and possibly think about fluid, vasoconstriction, inotropic management before you just crank up the PEEP and the ventilator. So keep an eye on the arterial trace when you are fiddling with the ventilator. Right, kidneys. So 24-hour fluid balance is probably the most useful thing that we do. There's all sorts of voodoo about whether you take off a magic 1,000 mils for insensible losses. As long as you're consistent and do what they did the day before, that's probably good enough. But just bear in mind that what goes in isn't always totally measured, and certainly what comes out or evaporates is definitely not always measured particularly well. So fluid balance is really important. What's the trend in the U's and E's? So some of these patients will get acute renal impairment, acute renal failure. You don't always need to start someone in renal failure on renal replacement therapy. The classic indication will be a persistent acidosis that we can't fix through other measures, such as bicarb administration, volume overload that's causing a problem, hyperkalemia, so potassium that's rising and is starting to cause problems, so typically rising above 6, or symptomatic uremia. And that's more of a problem when we're trying to wake somebody up. If they won't wake up and the urea is 35, then we don't know whether it's the sedation or the uremia which is causing a problem. Different units have different approaches for this. It's likely that we will be a bit short of nurses and possibly equipment to provide mass renal replacement therapy. So we'll be looking to provide short, sharp, high intensity dialysis, if you like, renal support for those patients who really need it. But even if you're anuric, you often don't need to be on continuous renal replacement therapy. That's something that we'll have to take an overview of amongst the people who are managing the intensive care patients. In renal failure and in the fluid shifts that happen in intensive care, drug metabolism and drug accumulation can be a bit of a problem. There's some really good guides. The renal handbook is really useful. And just talk to staff. Sometimes we administer antibiotics differently if you're on dialysis or not. And essentially just assume all drugs will accumulate in a degree of renal failure. So we've often just got to back off on what we're administering. For the gut, it's a clinical examination. Does the patient wince when you prod them in the belly? Have they got bowel sounds? Does the abdomen feel distended or soft? We'll try and feed all of our patients, and we'll try and feed them typically continuously. There'll be local insulin prescriptions and strategies to think about. If you stop the feed, stop the insulin. Different units have different views on how you manage diabetic patients, but the simplest way is if you've got continuous feed with a continuous short-acting act-rapid type insulin infusion, but you'll have a protocol for that locally. Full feed is probably as good a GI protection as you need. So typically you can stop using proton pump inhibitors or things to protect the stomach once a patient is on full feed. You might need prokinetics such as Maxolon, metoclopramide or erythromycin in bolus intravenous form to get the guts going in someone who's critically ill. Have they opened the bowels today? That's important. Do they need laxatives, particularly on an opiate infusion? And occasionally these patients will develop surgical problems that we need surgical advice for. But simple things like, can we get them on full feed? If not, how can we get there? And have they opened their bowels? We need to keep things moving, unfortunately. Okay, microbiology is really important. Why are they on antibiotics? Who put them on the antibiotics? What do we have some advice about that? When did they start? How long is the planned treatment course? Are really important questions, particularly if it's a patient you weren't managing the day before. And it can be really frustrating trying to work out what someone's on and why. So please be as clear as you can about the antimicrobial plan. Unfortunately, that's likely to change depending on the nature of the patient and how they're getting on. We need to think about current samples and results from those samples. Do we need new samples? So whenever a patient gets ventilated, think about, have they got adequate samples? Do we know the diagnosis? Do we need to do a bronch? Do we need to do an endocrine aspirate while we're at it? Any relevant positives, remembering that it's probably going to be a bit chaotic looking at results for these patients. So if you have time, have a look. Are there any new positive results that we've got? The best thing I can advise you to do is to download the micro guide to your smartphone. Now, there are specific guides for each trust, which should be updated regularly. So you can see I've downloaded the one that was updated this week, relevant for our trust. So these are our guidelines, which you can have in your pocket. There is a COVID-19 section, and there's sections for every other antibiotic as well. So this might change. Current guidance is that these patients have a community-acquired pneumonia, although it's likely to be viral. We are covering them with antibiotics as well. That's likely to be short-term boluses, and what we use might change. So keep an eye on that. Desktop versions are available if you don't fancy getting your smartphone out in a COVID zone, so bear that in mind. The other things we need to do to complete our daily review, or think about the lines a patient might have, review their bloods, and then think about DVT prophylaxis, which is really important. So quick refresher about central lines. So obviously internal jugular, subclavian or femoral are the classic access sites. We will put PICC lines, peripheral inserted central cannula, into antecubital fosses. So patients may have tunneled lines, etc. But these are the sites that we'll typically use. Strict asepsis, so like you're going to do surgery. So, don't cut corners because it's busy, because a line infection is obviously bad news for a patient. Use ultrasound where possible. That's the safest way to do it. We might be short of ultrasound machines, so clearly that's going to have to be a judgment call. But if you're trained to use ultrasound and that's how you normally put them in, then I strongly recommend that's how you continue to put them in. If you can't get a line in, don't persist, because you're more likely to have problems. Either change site, change side, or ask for some help. And all lines in the neck or chest will need a chest x-ray at some point. Now, if you're used to putting in a central line at the start of a theatre case, using it for 6 hours and getting a chest x-ray afterwards, that's fine. Putting a central line, if you're happy it's gone in the right place, if you've aspirated blood, if there's a central venous waveform, you can use that line straight away, but you'll need a chest x-ray at some point, okay? And again, just being clear to explain to people that, yes, we're happy to use this line, but I've ordered a chest x-ray, which will happen at some point. If you order an x-ray, make sure that either you or somebody else looks at it and writes down that it's either okay or if the line needs some intervention. And certainly with Ensure, we've got a fairly standard form for line insertion. A refresher about lines. So right internal jugular lines are the easiest lines to put in if you're good at putting in central lines. Low complication rate, complications typically pneumothorax or pranging something else in the neck like the carotid. Infection risk, probably medium. It's around the patient's neck and hair. They dribble on them, they move around, and then the line moves a bit. But they're fairly accessible. They're out of the way of the dirty parts of the body. And probably a fairly low thrombus risk if they're connected to a continuous flushing system. Subclavian lines are a bit more tricky to insert, particularly if you're not used to doing them. So I wouldn't recommend you start using subclavian lines if you're not good at them. You can use ultrasound, although it's a bit more tricky. You can take a more lateral approach and use ultrasounds if you're good at it. But again, I would avoid subclavians if you're not good at putting them in. Medium risk complications, because if you hit something under the clavicle, clearly it's a bit more tricky to press on it, particularly the subclavian artery, and pneumothoraces rates are higher. Infection risk is probably the lowest for a subclavian. It's the most out of the way line. It's easy to keep clean. It's relatively fixed in position. So there are some advantages. It can scupper your great veins for later fistula, for renal failure management, etc. So they're not ideal in all situations, and they probably have got just about the same thrombus risk as a subclavian line. Femoral lines are pretty easy. Again, I would encourage you to use ultrasound, but they're probably the line that you could do without ultrasound if you had to. Pretty low complication rate because it's easy to press on an artery or a vein if you hit something you shouldn't have hit. Be careful not to go under the inguinal ligament too much because clearly that's more tricky. There's more things in there to hit. A higher infection risk because it's in the patient's groin, and the thrombus risk down there is pretty high. So we tend to avoid femoral lines if we can because of infection and thrombosis risk. For the COVID patients, ideally you'd put left-sided lines in. That's because if they need ECMO, they're going to need the right IJ to get into the right side of the heart for their ECMO cannula. So left-sided lines are preferable, be that in the neck or be that in the groin. Most patients, the vast majority, are not going to be ECMO candidates, and we're not going to have the ECMO capacity. So it's a consideration for people who may need ECMO. They're typically going to be patients who are really sick very early in their treatment disease, who are young with single organ failure. If you do need ECMO cannula, they typically stick a double lumen, great big Avalon catheter into the right IJ. So you can swap a line that's there already, not the end of the world, but ideally you would avoid it. And sometimes they need an additional femoral line, which is typically on the right as well. Okay, so we finished our daily review. I think it's really useful to think of a summary. So imagine you're presenting this on a ward round. So can you summarise what's going on in one sentence? So this is Mr. Smith, who pitched up 3 days ago, got ventilated yesterday. He's got confirmed COVID infection. At the moment, is relatively easy to ventilate. Problems, we don't know his past medical history. His vasopressor requirement is quite high. And we haven't spoken to his family yet, something like that. So what are the problems today and what are we going to do about them? And documenting who's seen the patient, what is the senior review, has that led to a change in plan, and being clear if there is a plan, i.e. take some bloods, do a bronch, turn the patient prone, who's going to do that? So, there's nothing more frustrating than a beautiful plan that no one actually does. So planning involves delegating who's going to actually do it, and then maybe going back and checking that that's been done, or checking the results, or seeing what's happened. So again, it's about communication and being very sort of picky about who's doing what and what are we going to do. So last couple of minutes, I'm going to talk about particularly managing the COVID-19 infected ICU patient. I have pinched some advice from our colleagues in the Northern Care Alliance, and thank you to Jay and colleagues who've let me nick their stuff and talk about it. We should be triaging these patients, and we're going to be thinking quite carefully about who gets intubated and ventilated. We need to be wearing full PPE for all interactions with these patients. There are different grades of PPE. If you're just entering an area where there's some patients, you need certain protection. If you're doing aerosol generating procedures, if you're at the bedside, you're going to need a higher level of protection. Most patients are going to be managed on sealed circuits, closed circuits, on ventilators with closed suction, etc. So the risks are mitigated to some extent. We've already talked about avoiding lines when you get someone off to sleep. If you're the person managing their airway, think about putting in nasogastric tubes at the same time. That's really useful. A urinary catheter is really useful. There's various documentations about nasogastric tube and checking because we really don't want to be feeding people into their lungs. But if you're managing the airway, it's usually pretty easy to see where you've put the NG tube, particularly with a video laryngoscope. But we need to check that the tip of the tube is in the stomach, and there is local documentation to be explicit about where the tip of the NG tube is for any patient. Ventilation is important, and we do that based on their ideal body weight. And so we need to calculate it, or we need to measure it. You can measure it from normograms, you can estimate it, but there's different ways and different units of measuring it, from your ulnar length, or you can estimate it from the height. But ideal body weight is what we will use to set our ventilation targets. Think about, is it something else? Do they have a bacterial infection? Is it the flu? Have they had a PE? Do we need to take respiratory samples? Taking respiratory samples may be a relatively high risk thing to do. So endotracheal aspirates with a closed system will be the safest way to do it. Again, our nurses will likely be the people doing that. Physiotherapists are really good at taking bronchial lavage samples and non-directed NBL bronchial lavage samples, or they might need something a bit more invasive with a bronchoscope. If you're not used to using a bronchoscope, don't do it, because there are some peculiarities to handling samples with a bronch, and you don't want to be splashing around everywhere. We need to prescribe our ventilation and oxygenation goals. I'll talk about that in a sec. To start with, probably need to sedate patients quite deeply so that they are compliant with ventilation. And we've talked about maintaining an adequate map, so just enough, not too much. We can probably meet our fluid requirements with 24-hour feed and with the drug boluses that we give. So they shouldn't need maintenance IV fluids for these COVID patients, because we're trying to keep the lungs dry. Your lungs are like a sponge. The soggier they are, the less air in them. So try and keep people dry. We're not trying to resuscitate them cardiovascularly unless there's evidence of shock. So end organ hypoperfusion. So don't just be liberal with your fluid just because they're ventilated and they're sick. This idea of a do no more harm ventilation strategy is quite a good one. So they might need a recruitment maneuver, so some sort of lung expansion maneuver, particularly if they've been struggling for a bit prior to intubation. Recruitment maneuvers, we're talking about 30 centimetres of water for 30 seconds with the ventilator. I would advise you to look at the arterial trace when you're doing that, because we talked about the cardiac interactions. The higher the pressure, the less the venous return. So you might have to release that recruitment manoeuvre. You can just turn up tidal volume for 10 minutes or so, but remember obviously to take it down again. 6 mils per kilogram is our ideal body weight volume target. So that works out around 420 mils for a 70 kilogram man. IE ratio we've talked about, but typically 1 to 1.5, something like that for a hypoxic patient, remembering to increase it again as they get better. Target SATs, as we said, you don't need to be heroic with your oxygenation. A PEEP ladder, remembering the more PEEP we use, the more trouble the heart may be in. Just bear that in mind. Always trying to keep our plateau pressures, so that's the pressure when inspiration settles. That's the pressure that we're trying to keep it under. If you keep the pressure under about 30 centimetres of water, then the risk of complications like pneumothoraces and ARDS is dramatically reduced. There is some evidence that paralysing people early in ARDS reduces problems down the line. For people with compliant lungs, we don't always do that, but there may be a local reason to do that. As long as they're not too acidotic, we can accept a high CO2. It doesn't matter too much. We might need to use bicarbonate infusions. Again, be careful with volume if you're using bicarb. We've talked a little bit about breath stacking and respiratory rates and making sure the patient is exhaling adequately. We might need to use diuretics like furosemide to maintain a negative fluid balance, because that's probably going to be good for the lungs. That may be bad for the kidneys and the heart. And again, that's something that we look at balancing the patient when we review them twice daily. We might need to prone the patient, and the typical indications for proning is if the FiO2 is over about 60% and the PEEP is high. And we've done our recruitment manoeuvres, we've fiddled with the IE ratio. Prone positioning is a pain for staff, it's a pain for the patient, it requires lots of additional considerations for nursing care, but it can be really effective. And typically we do that for 16 hours out of 24 and keep doing it until we have a sustained improvement. So proning is something that's quite simple that can be very effective and quite dramatically effective in both oxygenation and sometimes hypercarbia. Fairly crude sort of ARDS guidance around how much oxygen you're on, how much PEEP you get. So turn up the PEEP as you turn up the FiO2. That can start to cause problems with inspiratory pressure, but again, try and keep that under 30 centimetres of water. If the ventilation changes, check for new problems. Is there pneumothorax? Is there bronchospasm? Is there something that's developing which is causing a new problem? They might need to be sedated more deeply. They might need to be paralysed. Think about your IE ratio. Think about recruitment manoeuvres. Do we need to prone them? Do we need to think about different modes of ventilation? So there are other modes of ventilation which you're probably less familiar with, but APRV, for example, is something that we might use. And then consideration for ECMO, although that's going to be a pretty small section of patients. So if they're acidotic, if they're hypoxic, despite all those things, think about a chest x-ray, think about aggressive fluid removal, which might need renal filtration. If there's evidence of collapse or plugging off, they might need a quick bronch. That can be pretty sporting, so that should be an intensivist doing that. We've talked about proning. Think about an echo if we're worried about the right heart. And there are guidance out there for both ECMO and our Greater Manchester and other resources about lung protective ventilation. But it's basically about controlling the pressure and controlling that tidal volume, aiming for that 6 mils per kilogram. As a general ongoing management of these patients, they need at least twice daily medical review, more frequently if they're sick. There might be some research opportunities we need to think about. So public health research could be important for these patients. Remember, we've talked about the cardiac interactions of our ventilation strategy. Ideally for fluids, we'd be using albumin in the UK. We don't use synthetic colloids. They are bad for your kidneys. So we avoid them. We typically use Hartmann's as our go-to crystalloid if we need to use a crystalloid. But for these particular patients, the advice currently is not to give routine maintenance fluid. Now, if they're not absorbing their feed, we might need to think about some fluid replacements, but typically we're looking for a negative fluid balance. And patients can generally cope with that and the cardiovascular implications of that if they're young and fit. Now, clearly that might change depending on the patient and their disease course, but the principle is to keep them dry. There's no role for steroids in this situation. Again, the therapy specific for COVID might evolve over the coming likely weeks, probably not days. Sometimes in people on high vasopressors, we sometimes use a little bit of hydrocortisone, but again, that's the evidence base behind that is a bit weak. So please talk to someone before thinking about a little bit of hydrocortisone, and as a rule, we're not giving steroids to these patients. This mnemonic is about thinking about what we need to do to progress the care of this patient. So is it worth a sedation hold or trial them on a spontaneous mode of ventilation? So typically when they're on less than 50% oxygen and the PEEP is less than 10, we might think about, are they ready to wake up? Think about the lines every day. Are they clean? Do we need them? Can we take them out? We don't routinely change lines on day 7 or day 10. If they're clean, they're fine. If lines start to have blocked lumens, that start to tell us they need to come out. And we can manage patients without central lines on an ICU. But typically, if they're on a vasopressor, then we'll need a central line. Think each day about analgesia, the sedation strategy, the drugs they're on. Are they accumulating? Are they interacting? Look all the drugs up. We're fortunate we have really good pharmacists that work in critical care. They're there for advice. They might be a bit busy too. So just look the drugs up. We've talked about ventilation, enteral feed, and then DVT prophylaxis. Delirium might be a problem. We can try and avoid it by talking to patients, by minimizing sedation, orientating them as best as we can. And then we sometimes need to use drugs. So typically haloperidol or drugs like quetiapine or risperidone to proactively treat delirium. if you're not used to looking for delirium or treating it, again, please ask for some advice, because that's a tricky thing to do. But I think the take-home message is that we can do this. We've all got transferable skills. We can look after patients perfectly well with our transferable skills. It's going to be difficult. It's going to be tricky. We're going to have some difficult situations, but patients can be managed with critical illnesses by all of us pulling together and sorting them out. There's a few principles, and I hope I've covered those here. I'm happy to do this again. I'm happy to do this live, and I'm happy to have a Q&A, and we'll make these videos and some resources available locally as best as we can. So thank you for listening. I hope you found that useful, and hopefully I'll see some of you around. Okay, bye-bye.